Dr. Jane, and today I'm going to be talking to you about the clinical side of pancreatic cancer.
Hi, I'm Dr. Atia, and I'll be talking to you about the research side of pancreatic cancer.
We'll start by taking you through the onset of pancreatic cancer.
Diagnosing pancreatic cancer can actually be a tricky business because its onset isn't always so apparent. In fact, the first signs and symptoms often don't appear until much later into the pancreatic cancer. You will notice though that there are symptoms like low mood or depression, indigestion, diabetes, pale and smelly stools, and jaundice, which is like the yellowing of the skin and eyes. You might also experience pain in the mid-back, upper abdominal, and while eating, you'll also get fatigue and unexplained weight loss. One of the problems with pancreatic cancer is that while we do know it's an issue related to the transduction pathway and cell growth, what we don't know is what causes the mutation in those cells. What we can tell you now is that we do know some of the risk factors. Inflammation of the pancreas, family history, obesity, ethnicity, diabetes, and smoking can all be relevant factors in determining your risk for pancreatic cancer.
On the left side, we have the normal cell signaling pathway. At the top is the off-RAS GDP, a protein binded to guanosine diphosphate. Signal molecules are sent to GFs, guanosine nucleotide exchange factors, that turn DDP into GTP, guanosine triphosphate. After this phosphorylation, RAS GTP sends important things like cytokines, inflammatory mediators, and growth factors to the body. At the end, GAPs, GTPase activated proteins, hydrolyze the RAS GTP, turning it back into off-RAS GDP. In the broken pathway on the right, there's a mutation in the last part, which leaves the RAS GTP on longer than necessary, sending unneeded cytokines, growth factors, and inflammatory mediators. When looking to the prognosis and statistics of pancreatic cancer, many patients live up to 5 years. Those without resection or Whipple surgery have a 7% survival rate, while those with resection or Whipple surgery have a 10% survival rate, but it can reach up to 20 or 30%. When looking at specific stages, localized pancreatic cancer has a 34% 5-year survival rate, but in best case scenario. Regional pancreatic cancer has only a 12% 5-year survival rate, and distant pancreatic cancer has a 3% survival rate. Now, back to Dr. Jane.
Right now, when we look to treatment, there are two primary ways we can go about it. Surgery, which removes the cancerous tumor, but that can only be done if it hasn't really spread to the arteries, and again, it's very dangerous. At the bottom, you have chemotherapy, which is primarily using the drug gemcitabine. That destroys the cells almost entirely.
When looking to current cancer research, we found that inhibition is the most effective way at treating pancreatic cancer without destroying cells. A trial with mice was done which found that the addition of the KRAS protein was needed for the protection of tumor cells. If we were able to target it in a human cell, we could make strides forward in cancer treatment. Dr. Channing Dare from the UNC School of Pharmacology agrees, asserting that KRAS inhibition could be the holy grail in cancer research.